Good afternoon. Let's look at some information on infectious diarrhea. I think the encouraging part is that as we become more educated and prepared to take care of patients with infectious diarrhea or with diarrhea presentations, then we will become experts at really being able to educate and implement some prevention strategies for diarrhea. So again, I'm going to set your lecture up very much like Butera sets our chapters up, and I'm going to extract the most important data I want you to know. So diarrhea is an alteration of normal bowel movement. It's characterized by increase in volume and frequency in stools. But there is a way that we can differentiate, like gastroenteritis, viral gastroenteritis, and food poisoning versus diarrhea that is either from a upper or a lower bowel pathogen. So let's look at that. So if the predominant symptoms are nausea and vomiting, then you need to consider viral gastroenteritis and or food poisoning. And remember that norovirus in adults is the most common cause, and rotavirus in children. If the predominant symptom is diarrhea, then an upper or a lower bowel pathogen should be considered. Okay, so then when you're considering the small intestines being the origin of the diarrhea, remember that those patients will present with less frequent or less than 6 bowel movements in a 24-hour period, small volume, and non-inflammatory. Some of the causes of that are E. coli and Giardia. If it is from the lower bowel or colon, then you are going to see that the pathogen causes frequent, greater than 6 bowel movements in a 24-hour period, large volume, and inflammatory diarrhea. And inflammatory diarrhea typically also is accompanied by fever, mucus, and blood in the stool. Some of the causes for that are Shigella, Salmonella, and Clostridium difficile. So from an epidemiologic standpoint, we've got to think about it being so significant. It's the second leading cause of morbidity and mortality in the world, but in the United States, about each person in the U.S. has an average of 1 to 2 annual bouts of some form of diarrhea, and resulting in about 3,000 to 5,000 deaths annually. Now, in contrast to developing nations, much higher morbidity mortality, I believe the statistic I read said at least 6 bouts of diarrheal illness for a annual occurrence. And, you know, there's a lot of complex issues, socioeconomic issues related to why increased morbidity and mortality does occur. But unfortunately, rotavirus being the most common cause of viral gastroenteritis in childhood, even in the United States, shares a proclivity to cause death in malnourished children. So this is very serious. There's 3 main routes of transmission: food-borne, waterborne, and person-to-person or fecal-oral. And again, let me reiterate that norovirus has become the most common food-borne cause of diarrhea in adults. So pathophysiology considerations do include that diarrhea is caused by a virus, a bacteria, or a parasite. And there's some clues or cues that we can use. Viral diarrhea or cause of diarrhea is year-round. It does peak in the winter. Bacterial diarrhea cause of diarrhea is more common in the summer and early fall. And I also want you to think about acute infectious diarrhea as being either non-inflammatory, inflammatory, or penetrating. Okay? And then there's 4 pathogenic mechanisms of diarrhea, unfortunately. There's adherence. It's the bowels colonized by bacteria with small adherents, that are non-adherent and suppress overgrowth of more pathogenic bacteria. Pathogenic bacteria may adhere to the bowel wall and cause direct damage. Invasion, invasive organisms adhere to the enterocytes and they invade the bowel wall with ulceration, sloughing of tissue, blood, and mucus. Enterotoxin, when you think of Vibrio cholera, it's a classic example. It acts as a second messenger, cyclic adenosine monophosphate, to the chloride channels in the apical epithelial cells, block sodium chloride absorption, and in addition, increase chloride secretion by the crypt cells. That's complicated. I don't need you to memorize it, but remember that enterotoxin can be quite lethal. Cytotoxins, Shigella is an example of classic cytotoxin that damaged the mucosa by inhibiting cellular protein synthesis and producing an inflammatory colitis. So in clinical presentation, you have to really take a thorough history. It's imperative to determine the cause, and determining the cause will determine the management and treatment. So again, in the United States, the most infectious diarrhea seen is caused by norovirus, 50 to 80%. So that's a non-inflammatory, less than 6 low-volume diarrheal movements, and the provider must investigate this closely, and you are to only give antibiotics for presentations not consistent with norovirus. It's a virus. It doesn't need an antibiotic. So pretty much statistically, if that person in front of you is complaining of diarrhea, there's a likelihood that it's norovirus, but you have to have more information than that. So you also could turn to look at and add the epidemiologic cues or clues, okay? And just a few, those are on page 1245, would be, have they recently traveled internationally? Is it an infant in a daycare center or an adult in a daycare or a nursing home? Has it been a hospitalized patient or someone just off of antibiotics? So there's other clues that'll help you in your diagnosis. Consider bacterial causes of diarrhea when you see fever, abdominal pain, tenesmus. Remember, that's that rectal pain and spasm. Large volume diarrhea, greater than 6 stools per day, and mucus or blood in the stool. Chronic diarrhea, greater than 14 days, is suggestive of protozoan parasites, and that's when we obtain an O&P. Chronic or recurrent diarrhea is suggestive of inflammatory bowel disorders, but other things come with inflammatory diarrhea that we have mentioned previously. And then irritable bowel syndrome may present as diarrhea predominant form. So in our physical exam, it's imperative we get a weight, temperature, orthostatic vital signs that include both the blood pressure and the pulse, and you're looking specifically at volume depletion. You look at mental status, skin color, temperature, and rashes. Perforation reflects a quiet auscultation and rigidity with palpation. Perforation of the bowel. Small bowel obstruction, you're going to see a tender abdomen, distended, high-pitched bowel sounds. If one of your differentials is hyperthyroidism as a cause of diarrhea, the patient will have thyromegaly, tachycardia, and proptosis, the bulging eyes. And actually, it's tissue that forms behind the eye that makes the eye look protruding. When you do see lymphadenopathy, especially the cervical nodes, you must consider that lymphoma or a bowel cancer is a cause of diarrhea. Now, they could have more than one problem, but this is a differential for diarrhea. Females with lower abdominal symptoms require pelvic exam, even in the presence of diarrhea, because you have to rule out PID, you have to rule out a pregnancy in the tubes. So that's just part of a comprehensive exam. In the elderly, it's imperative that fecal impaction is ruled out as the cause of diarrhea. And now we do consider all adult patients are tested for HIV or should be. And if they present with diarrhea, it could be an indication. So that has to be in your differentials. Diagnostically, mild acute diarrhea or gastroenteritis doesn't typically indicate a need for diagnostics. We do, though, if it's moderate to severe, obtain CBC, serum electrolytes, blood urea nitrogen, and creatinine. They're just standards for evaluation of electrolyte derangement and dehydration. Stool sample for leukocytes and occult blood for patients that present with a temp over 102, bloody diarrhea, abdominal pain, greater than 6 stools a day, and for the frail, elderly, or the immunocompromised. Stool cultures for O and P are often indicated, particularly in those patients that have had diarrhea 14 days or greater. Stool for C. difficile, and for a variant of E. coli called EHEC. Colonoscopy may be indicated at times, but there's a danger of perforation, and that goes beyond our scope of practice at this point as primary care providers. CT is usually the radiologic test of choice to discover mucosal thickening, hemorrhage, abscess, malignancy, or inflammatory colitis. So how do we manage infectious diarrhea? Non-inflammatory with oral rehydration therapy. Traveler's diarrhea, oral rehydration therapy, Imodium, at times ciprofloxacin, azithromycin. We do use bismuth that has a non-diarrheal and an antibiotic property. That's Pepto-Bismol, but prevention is cornerstone of treatment. As far as inflammatory, diarrhea, which implies bacterial oral rehydration therapy, and if needed, moderate to severe cases, we'll use antibiotics such as Cipro. Clostridium difficile, we use metronidazole, which is Flagyl, and vancomycin can be used, but it just depends on the situation. There's a lot of problems and resistance in treating C. difficile. So food poisoning is generally symptomatic. It's relief of nausea and vomiting and cramps and diarrhea and just preventing dehydration. And then finally, our referrals are based on clinical judgment and the individual patient. We certainly seek hospitalization for dehydration and intractable vomiting. Medical evaluations needed for children under 6 months. Infants and children with fever, bloody stool, high volume stool, persistent vomiting. And these small children and compromised patients, they can go bad really quickly, so they need very frequent reevaluation. Patient education and health promotion includes a lot of education with patients with C. difficile about not reinfecting, that it's a slow recovery process. We have got to be vigilant to avoid non-essential antibiotics. Children under 5 have an increased risk of bowel intussusception 6 months within that 6-month period after bacterial enteritis. So that's important to know. Hand washing is imperative. Safe handling of food. Drink frequent small sips of fluid to avoid dehydration. Avoid foods and let the stomach rest until BMs begin to return to normal. Hydration is the priority. Better to avoid antidiarrheals if at all possible. And if symptoms persist or worsen, they must seek medical care. Thank you for your attention.